Okay, so we're back, Sunset Advisory Commission. And we need to have a little discussion about the names here and why we named this commission, because it really shouldn't be a commission. It should be a committee or a task force, right? But that's an internal discussion that we'll have. But anyway, so we are looking at the different boards and committees and commissions and task forces to see if they still need to exist. And if they do, is it the appropriate, is there, if the function needs to continue to exist, is it still the appropriate entity to be doing that function? And do there need to be legislative changes that we can address to the legislature in our report? So with that, I think we will introduce ourselves first and then we'll get going. And I'm Jeanette White from Windham County. Hi, David.
John Gannon, representing Halifax, Whitingham, and Wilmington in Southern Vermont.
Rob Leclerc, Barry County.
I'm Matt Krause. I'm one of the gubernatorial appointees.
Senator Colin Moore from Rutland.
I'm Tracy DeLude. I'm the appointments director and the other gubernatorial appointee.
And in the room with us, we have Amron, who's our council person, and Andrea, who takes care of us. So, David, would you like to talk to us about the Board of Medical Practice?
Sure. The Board of Medical Practice is located within the Department of Health, and I'm the appointed executive director. We have a small staff. We have 5 full-time employees other than myself, and then have some assistant attorneys general under MOU with the AG's office help us out. And then we have 17 board members. Our 17 members are 9 physicians, 1 PA, 1 podiatrist, and 6 public members who can have no association with the practice of medicine. The board exists to license and regulate the practice of medicine by allopathic physicians, MDs. I say that word, a lot of people aren't familiar with it because that's as opposed to osteopathic physicians. There's a separate board for the osteopaths that exists in OPR. And we also regulate PAs, podiatrists, podiatrists in training who are in residence, MDs who are in training. We have quite a few of those, both the ones at UVM and at Dartmouth Hitchcock do a lot of rotations in Vermont and get licenses to practice doing placements in Vermont. And then we have 2 other lesser known professions, anesthesiologist assistants and radiologist assistants, who are sort of the whole practitioner in the way a PA is. They have higher level duties, but are not full-fledged physicians. What we do is we license physicians, and when primarily it is physicians. We are up to we're getting close to 5,000 physicians now. We've had quite an uptick since Vermont joined the Interstate Medical Licensure Compact. And with the explosion of telemedicine, especially during COVID, it's really ticked up a little bit. We used to run around 4,000 and sort of a saw progression up during the 2-year cycle in which licenses are issued. We go up, and then when renewal comes, we drop off a little bit and then go back up again. So we're pretty high now. We have about 400, a little bit more than 400 PAs, and then all the others are slightly smaller numbers. Well, MD residents, there's quite a few of them as well. And in licensing them, we do quite a bit of work verifying their education, their training, and their moral readiness to practice. It's quite an intensive process, a little bit more than many of the professions. We also regulate practice, and we do that in a couple different ways. One is that the board is involved in making rules, the rules that have to do with the board and how we operate, and also the Department of Health rules that the commissioner is directed to make by law regarding medical issues. And a good example of that is the rule regarding the treatment of pain with opioids. And the board has a seat at the table with that and all the other rules that they have to do with medical issues. We spend a lot of our time investigating complaints and other cases that come to us without complaints to ensure that our licensees are practicing without committing unprofessional conduct in accordance with the standard of care. And in an average year, we have anywhere from 150 to as many as 300 cases. We get reports of every malpractice, settlement, or verdict against a licensee. And those cases are each reviewed by one of our 3 investigative committees. And the members make a determination whether or not the case should be opened up and investigated. Normally get medical records and spend a lot of time going over just what it was that happened in the case that caused there to the payment to the former patient. So the way we operate, we have 3 different committees that are set up according to geography. And so we have a north, a central, and a southern committee, and cases are assigned to avoid conflicts. So if we have a complaint brought against somebody in the Burlington area, which is part of our north region, the case would be assigned to the central or southern committee, because obviously there's a lot of connection, and everybody knows everybody in Vermont, and so it really cuts down a lot. We still have a fair number of cases where a member or 2 might have to recuse from a case. So when the cases go to the investigative committee, they act, they're wearing their hat that looks like a prosecutor's hat. They direct the staff or investigators who are certified law enforcement officers. They direct me and the investigators and what they need and what direction the case is going to take. Do they need more information? Is the case ready to be closed? They don't close the case. They make a recommendation to the full board, the rest of the members who are presented the case in an executive session, a closed session at a board meeting, and they approve closing a case when, or don't approve closing a case and say, we think you need to do more, or we think there ought to be charges. But that's in a nutshell how it works. And then we have, I said, we do about 150 to 300 investigations here in average year. Most years we have about 15 to 20 actions. The largest portion of those are resolved with a stipulated agreement where, our licensees are almost always represented by counsel, and we negotiate an agreement to a resolution of the case. And very often the board really is not focused on being punitive, but on informing everybody who's out there, potential patients, potential employers, that there was a mistake made, or there was a problem, there was some unprofessional conduct. And also remediating whatever the deficiency may have been. So very often the board's orders include a condition that they must complete some remedial training. Sometimes there are special purpose exams that somebody can be required to take to verify that they do have current knowledge and that they are able to safely practice. We may impose conditions. Sometimes we've had cases where we've limited the ability of someone who has made mistakes, say in surgery, that they are not able to perform surgeries of certain kinds. So the entire focus of the board is on protecting the public and notifying the public and other interested parties, as I said, employers, insurance companies, to the board for information when they're making decisions about allowing physicians to take part in their insurance plan or to be covered by them for malpractice insurance or to employ them.
So I have a question. Does anybody else want to go first?
I have a couple of questions. Go ahead, Madam Chair.
So I guess my main question is, the board represents 5 different professions, an MD, you named them, but it's very heavily loaded with physicians. And I'm just curious if that is a result of people applying to the governor to be on the board, or it just seems that it's heavily,
It's in law. It was a decision of the legislature.
that it be, that be the,
Makeup with 9 physicians. And it's really, it's a fair reflection, I think, of the numbers. I mean, we have almost 5,000 physicians.
Right.
And 9 members are physicians. And then we have a PA, about 10 times as many physicians as our PAs. Podiatrists are actually overrepresented because we're unfortunately, if you know any podiatrists who come to Vermont, let them know. We need podiatrists. It's very important now with the explosion in diabetes. They're really needed. But anyway, we only have we have less than 50 podiatrists, and they have a member representing them. The anesthesiologist assistants and radiologist assistants, the numbers are really pretty low.
okay. But so I guess for some reason I didn't pick up that the numbers are set by the legislature. I did not.
It's
Okay, yeah,
in the law
yeah,
creating the board.
okay. Robert.
I get a couple questions. One, so what is your general annual budget? I'm looking at it here, and the board expenditures totaled $1,371,000 for fiscal year 22. Is that your budget or just what you spent?
That's what we spent. Most years so we get no general fund. We operate like a business.
So you're self-sustaining?
We're self-sustaining on our fees. The fees were last raised before. I've been with the board since January of 2011, and the last time the fees were raised, I meant to check on that, but I didn't have the white books in my office, and I didn't get a chance to figure it out. I think it was a few years before I got there, probably around 2009 was the last time that our physician fees were raised. The PH fees were adjusted. You were part of that. We PAs, they used to get a certificate for each work site, and we changed it so that they have a statewide license, and they're licensed now. And so the fee went up a little bit to reflect that they only had that one payment. It was cost neutral to the state or revenue neutral to the state, but otherwise our fees haven't gone up in many years.
You made the statement that your cases can fluctuate between, say, 150 to 300. How do you absorb those additional costs or cover those additional costs when you have a 300 case year? I don't, it's hard to characterize it
We work harder probably a little bit. Part of it, like when our numbers were really high, my first several years with the board, we were getting flooded. You have to look back at the history of opioid regulation. We were getting flooded with complaints by patients who were upset that their physicians were being more careful about how they prescribed, or who were refusing to prescribe once we started having rules about, you need to have periodic tests to verify that somebody is taking the being prescribed, to make all these improvements in practice to be safer in the way that opioids are prescribed. Then we started getting flooded with complaints from people who were really just angry. And, we would look into the case and there'd be a clear, the practice would be good and it would be documented, and, we'd get information about the individuals who maybe didn't have good credibility or whatever. And so those cases honestly don't take as much time for investigators or the board members as, sometimes we get really complex cases with just thousands of pages of records. So it boils down to working harder, and our meetings used to last longer when in a year when we have 300 or more cases, our meetings, would probably go an extra hour or two.
Why do you feel that you should be a standalone board when I'm hearing marked similarities between what you folks do in your structure and the Office of Professional Regulation as far as investigators and boards? And why do you need to be your own separate entity?
Well, I know I was around state government, and I think I was in the AG's office still, or maybe I was the commissioner or the general counsel at HR, and involved in the discussions about the personnel moves at the time. And I know there was a lot of unhappy history there. It didn't really work well for whatever reasons. I don't need to go into that, but seeing it from inside the health department, I think it's really good for the board to be there. There's a real synergy. It's a public health function. And
isn't nursing a public health function?
Yeah, arguably yes, but I think that, it's really tend to be the policy leaders in medicine, and our commissioner is a physician, and frankly, I think that the focus on public health, it really it's part of everything we do. We're, like I said, we have a seat at the table in the health department in so many different ways. I work regularly with the people who run the Vermont prescription monitoring system, people who work in substance use programs. I'm treated as a division director in the health department, and work on a regular basis, interact with my peers on different issues. And certainly, all during COVID, there is all different kinds of issues have come up over the years, and I really think that it's to the benefit of the board and to Vermonters to have a health department that's focused on the function as a health function, and not as just the administrative function of.
So I had the same question. I think that is probably an ongoing question that will continue to rear its head, because we really do have 4 major professions that aren't regulated by, or that the business function of regulation isn't under OPR, not the policies and stuff, but the business function of. And I think that those 4 will continue to kind of come up in discussions around.
I think, too, I'd like to just, I don't want to speak negatively about, comparing, but the board, we're separate from the osteopathic board. And there's 70 in the 50 states plus DC. And there's another couple of territories that are involved in the list, that counting all the medical boards, but there's 70 medical boards. So, there's about, 15 or 20 states that have separate boards like Vermont does for the osteopaths and the physicians. And I just, would submit that we've, in responding to the questions, as like, well, what's the objective data about how do we perform? And there's citizen groups have studied, and if you look at where the board comes out, our numbers, we're near the top in most of these ratings and different. And I'm not saying the criteria are perfect or mean that we're doing everything right, but we're coming out right near the top in a lot of these reviews about how do we communicate with the public. How many cases do we bring, serious disciplinary cases do we bring? And in that one, and the numbers there, it's not clear in the study, but if you look at, they had, that was just the physicians that they looked at in that public citizen report. They started with the premise of, across America, there's a certain, there's going to be a band of normal for how many actions are you going to have. It's not like the doctors are terrible in one state versus, and they presume that if you have vastly different numbers, that the board is doing things a little bit differently. And so I think that we're doing pretty well by that.
Yeah, I don't think that it is a question that will continue to come up, but it isn't the purview of this board necessarily to make that. I think we'd have to take a lot more testimony on that. I'm with you on this one, but I think we have to take a lot more testimony.
Sure,
before.
I just, but yeah, if they weren't self-supporting, I think it might be a different conversation, but because they are.
Yeah.
Okay, I get it,
But yeah, I see where you're going, and I think that it is something that will continue to come up.
So can I ask a couple quick questions? Mm-hmm. So David, as I understand it, your board looks at potential violations of medical practice, okay? And I happen to serve on the federal grand jury, and I remember a case where a physician was not in that venue. He was in a different venue where he was being investigated and ultimately was indicted for medical malpractice. So where's the line of why that individual ended up in a federal grand jury and somebody else ends up being disciplined by you folks?
Well, the line is always out there. It's potentially involved in every case we deal with, and that's a reason why our investigators are required and in the law are addressed as certified law enforcement officers. And it costs us money, their time training and having equipment for them and all. That's one of the reasons why. And so we have, with the opioids, the numbers have gone up to a certain extent. And so if we've been so fortunate. I mean, Vermont, we are a little bit different than many states. And we just haven't had the pill mills where, people are just out and out, make as much money as they can, like have been seen in some places. I don't want to pick on Alabama, but it was pretty bad there for a while in a lot of other states. But still, we have had cases where it rises to criminal conduct. We have had people who've been, they have their own substance use problem. With the Medicaid fraud, it can rise to criminal conduct. Unfortunately, even in Vermont, we have cases where there's sexual misconduct. And I don't know, just in the last couple of years, we've had a couple of cases that have been in the headlines. We had one physician who was engaged in voyeurism, filming coworkers at UVMMC. So the line is always there. We're ready to assist and very often work with prosecutors and the people who are focused full-time on crime.
Okay, so just so I'm clear, I heard you say opioids, et cetera. That had nothing to do with this particular case. So the only question I had was, where does your activities stop? And sort of like, okay, in this particular case was a federal grand jury indicting a physician. Sort of like, well, how does one end up in that bin and the rest end up in this bin? I mean.
Yeah, well, I think I know the case you're talking about. That's before my time, but I was in the AG's office then.
Right.
And so there's two different ways that in that case there were crimes coming up. One was insurance fraud or Medicaid fraud. Because of if it was unnecessary cataract surgery, is that what we're talking about here?
Yeah, I didn't want to.
I know, you were
Yeah.
and there's also, if you lie in getting informed consent from a patient to perform a surgery, and the surgery is unnecessary, it can also be an assault. So that's another crime that can be involved. So like I said, it's always there. We never know. In every case we start, there could be a crime.
Does it revolve at all around the prosecutors making a decision whether to charge someone or not?
Oh, absolutely. I mean, well, it's so.
Could they make a decision?
There are times when, like the state police or DEA or some other law enforcement agency knows about a case, and maybe we're working on it with them, or maybe they're working themselves, or maybe we're working on a case and we say, time to have a conversation. This is getting beyond our focus. It's something that we can deal with.
Who's the we that makes that determination? You?
It's me and the investigators, and we also, I told you, we always have board members involved, and we always discuss it with the board members. And that would be in the context that's in the investigative committees, which meet separately every month, apart from the full board, and they have their prosecutor hat on. And that's, when we'd have those conversations. And that comes up in specifically in our statutes. The board is assigned the role of investigating instances of unlicensed practice of medicine. So that's the only thing that's specifically assigned to the board that in law is saying you have to investigate this. But there's other ones. It can always come up. We start looking at somebody and saying, "Wow, did this patient need this prescription?" There's always the possibility that it was done with full knowledge and they were just doing it to make some extra money. Or maybe, worst case scenario, it could, there's cases out there, I see them reported all the time, mostly outside Vermont, but, it could happen here where maybe you have a physician who's prescribing in order to get, favors from a patient or whether it's sexual or just, to get something. We've had allegations that somebody was getting free work done on their house by somebody who was getting prescriptions, things like that. So
I just have one short question after this. I have just one question left. So I used to work at Central Vermont Medical Center, and malpractice was one of the top concerns at that time. We couldn't recruit physicians because the malpractice rates were so high. One time, I think we had 3 practicing pediatricians in central Vermont. So does your board have an impact on the malpractice rates, which impact recruitment? You said there's 5,000 physicians who practice. Yeah, but if you can't find any podiatrists because their malpractice rate is too high, you're not going to find them. I mean, they're not going to come here, or simple as that.
Well, I think that practice isn't what's keeping the podiatrist away. And some of the information I gave you, there's one of the bar graphs shows that Vermont's like among the fairly low malpractice, measured in terms of how much per capita is paid out in malpractice claims every year. And there's a system called the National Practitioner Data Bank. It's a federal office, and we're required by federal law to actions, all the malpractice insurers and employers who might pay on behalf of somebody. We all have to report. Hospitals have to report discipline. We report all our actions. Insurance companies report every settlement or payment award, and then so we know how much malpractice is addressed through the civil system. And we're separate from that. And if you're interested, I can spend a couple minutes telling you about why that's really important. But so the Vermont's malpractice is really quite low, and our malpractice insurance is much cheaper than in most states. And I think the other thing I'd say in response to the question about, well, how good a job is the board doing? Like, one of the things that a board might do badly is to raise the bar too high for licensing, or be too harsh, be too punitive on the licensees. And we enjoy the highest, in the states with the very highest level of medical care being provided by physicians. We're, in a lot of the measures, primary care, surgeons, MDs overall, we're in the top 5. And on some of them, we're 1 or 2. So when you look at per capita, how many physicians do we have, and how many, and the real truth teller, how many active physicians do you have? Because there's some physicians who are out there just, I don't know if it's because of telemedicine or because they probably collect licenses instead of teacups or something, but they have, 50 licenses. But we're right at the top on active physicians measured per capita.
I will say that the medical community, through the Medical Practice Board and other boards, along with the administration and the government operations committees over the last few years, have worked really hard to address the ongoing needs that came about because of COVID through telehealth, and also through change. When you talked about making the bar for licensing too high, it sort of prompted my thought on this, is around the changing some of the licensing requirements to allow for people, for example, who'd served in the military, who were fully licensed, but we needed to adjust some of our licensing requirements. And I think that between the administration, the profession, and the legislature, we came to some really good outcomes on those 2 issues.
Yeah, I think that's some excellent legislation that got started on the House side, I think.
I think it did not.
Cleaned up.
Yes, thank you, Matt. Any other questions or concerns, or?
Nope.
So how much do we get if a physician wants a license here but doesn't practice? Do we gain stuff? I mean, do we gain a whole pile of money? I mean,
Well, it's, for a 2-year license is $650.
Oh.
And that, part of that by law, it goes into the fund that supports our contract with the Vermont Practitioner Health Program, which, it's a whole nother story. I won't spend your time on that, but I think you're familiar with it. It's, we provide support to whatever kind of impairments a physician may have. And also the program acts as an advisor to the board. So then instead of getting into the, medical records and all the personal details of the licensee, we have the contracted program to keep it a little bit separate, and they advise us on the impaired physician. So anyway, so part of the money goes there.
Yeah.
They'll get that $650, but there's more. We worked on a telehealth bills the last couple of years a lot, and we have 2 new options for people who have less of a presence in Vermont, for all, not just physicians, but all healthcare practitioners. And they have the option of getting a very low cost telehealth registration, which has limits for how many patients they can have at a time. And then we also have a telehealth license, which has limits on how many patients they can have, but higher, so.
But if they're maintaining a license, don't they have to do CME?
Well, they do.
And is there any requirement to actually utilize their license and practice a limited amount?
No, they have to have the CME, which is, we're pretty typical and is, most physicians now are board certified, and most health plans won't let you be part of, get reimbursed through the health plan unless you're board certified. And board certification requires a lot more CME than we do. But so it's really, what we require for most, again, we're talking about it's for typical physicians, it really doesn't matter. We require 30 hours every 2 years, which isn't really a lot. And then we have 2 specific requirements. One is for, if you have a DEA license, controlled substances, you have to have a couple hours on prescribing practices. And everybody has to have an hour on end-of-life palliative care, pain management, those kinds of issues. And that's something that we actually get a lot of complaints about that. And there's a lot of problem with our multi-state practitioners with that one, because it's a little bit unusual. But that's in statute that we're required to have that requirement for our licensees.
Thank you.
Anything else? Thank you, David.
You're welcome.
Yeah, you're right. It was a slog between health and welfare and DevOps, but it worked out.
What's it, the telehealth?
Yeah.
Oh, God, yeah. And the task force. Oh, my God.
Yeah. Oh, yeah.
Meetings.
Forgot about the task force.
Yeah.
I wasn't on there, thank goodness.
So, well, thank you very much.
Thank you.
Thanks, good to see you.
Thank you.
see, David.
Okay, Eddie.
Oh,
So, I don't know what time is it right this minute?
11.
6 after.
Okay, so can you take us offline? You don't have that availability? Okay. Well, as soon as Andrea comes back in, do you know how to do it?
I might.
Oh, boy, here we go.
Oh,
Yeah, let's not touch the equipment there.